I'd like to welcome everyone tonight. I'm Beth Abramson. I'm one of the cardiologists who works here at the Toronto Heart Centre, and I run a prevention program and a large practice down at St. Mike's as well. And I want to take a few moments to just let you know that this is a sponsored evening by Amgen, and we want to thank them. I'm going to show you some disclosure slides in a minute. I also am going to let you know that this is being filmed, so that if you want to access this afterwards on a website, you can do so. So when you ask questions, obviously we'll talk about patients in particular, but we can talk after the fact. And this is an accredited program by Western and Schulich Medical School. So there were content experts in the committee in the review. So my disclosure is that I'm an equal opportunist and I'll speak for various companies, but I talk about issues and diseases and risk factors. I also, as you know, I've authored a book on prevention for the Heart and Stroke Foundation that has a focus on lifestyle as well and treating heart disease. But this program has received support from Amgen, and I've received funding from Amgen for tonight, but potentially Amgen could benefit from the sale of their new products down the road. That said, hopefully we will mitigate potential bias today by going over various issues, including talking about evidence-based information. And recommendations are made on evidence or guidelines, not on opinion. If there's a personal opinion, I will tell you when I'm giving you my personal opinion. And the material has been reviewed by an educational committee and has received CME credits. So this is an attempt to make it a non-biased evening tonight. So I'm going to go over some exciting what's up around the corner information for our patients with cholesterol issues. And I'm going to discuss some of the newer agents that are about to come on the market, that are undergoing clinical trial research right now, that I think are useful for us to understand as we see an evolving landscape of patients who are at risk for heart disease and have coronary heart disease, and how we treat them. I'm going to focus on some of the mechanism of action of these newer compounds, and I'm going to talk about how this may translate into treatment. I'm going to keep it in context as well about what we need to do to care for our patients on a daily basis. And I certainly will leave room for questions. I can give you my other disclosure, which I haven't given, is that I'm a busy clinician like all of you. And I spent today at Toronto Heart Centre. I was just telling my friend, saying we're being filmed here, so I'm not going to mention names, but I was just talking, a friend and colleague who I share patients with, that I saw patients here all day, I ran home, I saw my family, and now I'm back here because we're midtown, and that's very nice. But I'm going to try and keep it clinically focused and relevant. My other disclosure is that I have a master's of clinical epidemiology, and I'm not a basic scientist, so I'm going to take away, without any insult to the basic scientists in the room, and keep it very clinical. So we'll leave it and I will allow time for questions and answers. I usually like to make things interactive, but because we are being filmed tonight, if you can just jot down or keep your thoughts in terms of questions, we'll address them at the end, I think, for the interest of filming and timing. Okay, so there are some newer drugs that are emerging in terms of lipid lowering. As we get going, do I have a mouse for I don't know if I have a pointer or I have a mouse for an arrow, but that's okay. What we want to do is we want to talk about evolving drugs and lipid lowering management. And with all this AV support, I'm going to ask if they're looking for, either a laser pointer or a mouse for me to go on. But what we want to do is we want to look at some of the newer drugs, and I'm going to focus on a class of drugs called the PCSK9 inhibitors, because they are soon to be here for patient care. They are certainly here in clinical research trials, and it's something that is interesting that we should all be learning about to see where it will eventually land in the realm of clinical practice. So the PCSK9 inhibitors, we're going to go into a little detail. They increase LDL receptor levels, and so they increase the removal of LDL in the blood. Okay? There are several players being evaluated right now. There are some drugs out there that actually decrease LDL production. I'm not going to talk about these in detail. One or two of them on the market are available for compassionate use, but I think the cost of some of these drugs are so exorbitant at this point that really some of these drugs are really beyond the realm of any of us in primary care or tertiary care And there's one of this drug's probably available for patients. 10 patients in the country may be on it in the long run, and so we're not going to talk about that. And then there are other drugs that we have in terms of lipid-lowering therapy, as you may know, that we looked at in terms of CETP inhibitors to raise HDL. By and large, these compounds have been somewhat disappointing. There have been several drugs that have been taken off the market for futility, not off the market, but off the clinical trial program evaluation, because we thought that raising HDL would be good for our patients. It might be, but there's been futility in clinical trials. So going out and going for a brisk walk to raise HDL is probably better for all of us than trying some of these newer compounds. But there are still some compounds in ongoing evaluation, and you'll hear more about these in the next few years. I do think this is less of where we're going in terms of cholesterol management, however. So I was just going to ask, is there a laser pointer, or are we working on, there's no laser pointer? Is there a mouse I can use? No. Okay, so that's okay, no problem. So I can work around that, not a problem. Okay, so when we look at what we need and why do we need additional options for LDL lowering, it's true that many of our patients are at risk, and I apologize, I usually speak to you and don't look back at the slides because I have a slide projector in front of me, but we're making do in a very great clinical environment that is a good environment for giving a talk, but this is not a formal theater. So many patients who are high risk actually are not at their LDL goal on statins, and there are a lot of reasons for that. I think one of the issues has to do with suboptimal tolerance and adherence, and we can talk about this in the question and answer period, but I think we have to make sure we're actually treating our patients aggressively with evidence-based statin therapy before we skip to the newer classes of medications, because you and I, who run busy offices, have patients who are fearful of medications, who don't want to take them, and it's hard for us to get these patients on really evidence-based medications, and I don't think we should throw the baby out with the bathwater. That said, achieving an LDL cholesterol of under 2 in patients who are at high risk is often not possible with statins alone. And we all do have patients who are on high-dose statins who are at high future risk because they have established cardiovascular disease who are not at target. And so there's been a lot of data, and there's certainly observational studies that highlight the need for us to have newer treatment modalities for lipid lowering. And I think at the end of the day, it may be useful for some of our patients to have LDL lowering from different mechanisms. And you know, if LDL lowering comes from lifestyle in addition to therapy in many of our patients, that's also important as we talk about some of the newer drugs out there. So I have to state the obvious, but I'm going to go over this with you. This slide is a slide you may have seen before. The top line is secondary prevention. The bottom line is primary prevention for coronary heart disease. These are hard endpoint clinical trials. The details of each trial we don't have to talk about right now, but there is good evidence, and we can tell our patients that as well, that lowering LDL is associated with a lower reduction in coronary heart disease events. In fact, the clinical trial evidence is so strong that it amazes me the pop culture pushback for not using the class of drugs such as statins, which lower LDL effectively. Okay, so there's a lot of good trial evidence, and I often talk about hard endpoints. These are clinical trials which we refer to as hard endpoints or body bag trials, where we really are not just taking surrogates, but we're saying if you use this medication, if we lower LDL, you will have a lower risk of heart attack, stroke, or dying in the future. And I can't be more firm than that, and neither can you in your practice, yet we still have this pushback on a daily basis. That said, the issue about non-adherence is very prominent, and I just want to remind you that no matter how you look at it, statin therapy and statins are good drugs that lower morbidity and mortality. And this is a recent study that looked at adherence levels. And the patients who were adherent, and the adherent group is further away to your, I always get my left and my right confused as a physician because I'm always looking at x-rays. So to your left, I guess, as opposed to what? The green end. The green end, yes. Well, they're both green in the middle there, but I will tell you that the patients who were adherent to statin therapies had lower event rates than those who were non-adherent. And to be honest, this is a very powerful slide that shows that we should be really, really trying to go through a class of drugs before going on to other drugs or saying you don't need to be on a statin. And we all have anecdotes, but to be honest, I literally saw a patient in my office yesterday, so I'm here at the Toronto Heart Centre on Wednesdays, and I'm very busy the other days of the week at St. Michael's Hospital. And I have to say, I saw a patient who had a bypass 12 years ago who said he felt well and just said, you know, I didn't want to take my drugs. But we know that that patient's future risk of dying and disability is driven by coronary heart disease, and the bypass is the quick fix. And getting him, and there was a history of maybe there was some hepatitis that had resolved with completely normal enzymes on a low dose of a statin. And I turned to the resident and said, you know, we're not going to participate in this medical inertia. We're not going to send back. We're going to prescribe. We're going to give the patient follow-up with appropriate blood work and see what happens. I suspect the patient will be able to tolerate the statin that he was off of. Anyway, so it's something we need to keep in mind. Okay, so with that background of good drugs that we have available to us now, I'm going to go over some concepts of LDL lowering and bring into discussion the newer drugs that are going to be emerging on the market. So again, with apologies to the basic scientists, let's go over a few things. Firstly, LDL is bad. LDL receptors are good, okay? The more LDL receptors you have, the more LDL is taken out of the bloodstream. The lower the LDL levels that we have, I just showed you, translate into lower LDL event rates, and then I said, and more free time for clinicians. So there's an ulterior motive, right? Okay. So if we take this through, and this is an animated slide, I don't know if I'm in the right area because they're filming me, but so the serum LDL receptor binds LDL, and there are complex mechanisms within the body and within the liver actually to degrade the LDL receptor. Okay, and there's a recycling of the LDL receptor, so you have LDL receptors there. So PCSK9 inhibitors, okay, they actually interfere and work with LDL receptor degradation, okay? So in the presence of PCSK9 inhibitors, LDL receptors are sort of, PCSK9, not the inhibitors. It's been the end of a very long day and 2 weeks of call for the last 2 weeks. That's my other disclosure. Okay. The LDL receptors are taken out of the bloodstream, and the PCSK9 molecule is involved in that to make sure that our body has healthier receptors, but still takes receptors out of the system. Therefore, and it gets rid of the LDL receptor and the denigration process. So, if we now have a PCS, a monoclonal antibody that binds to the PCSK9 molecule and inhibits binding to the LDL receptor, it can't interfere with the recycling process of LDL receptors. So in the presence of a PCSK9 inhibitor, we have more LDL receptors recycled and up on the cell surface, less LDL in the body. That's the big concept. It sounds complicated, but it's actually not if we think about it and go through it. So I'm a cardiologist. I'm not a rheumatologist, and I'm getting used to new terminology because these are monoclonal antibodies. So I had a little bit of terminology 101 to show you. To show you this general suffix of these monoclonal antibodies, whether it's OMAB, Ixabab, Zumab, UBAB. Human monoclonal antibodies are 100% human. Humanized, 90% human, have the Zumab on the end. And the closer you are to a human monoclonal antibody, 100% human, the less likely you're going to have a chance of having immunogenicity or having side effects from the compound, okay? And so the newer compounds that we're going to be talking about are actually humanized or 100% human, okay? And so these are... To be honest, all of these compounds, and I will say this, I don't know what the price of them, they're all expensive compounds. I'm not sure it's more expensive to make them human or not. It's just the way the drug development went. And I can have, there are some people who have more expertise in the audience who may be able to answer that better, but they're all expensive. I don't know if it's more expensive to make them more humanized. It's just the development of the drug and where it occurred. And all of these drugs are under clinical trial development, and they're all costly. I don't know what the cost will be, and that's something that we'll have to grapple with as clinicians in the long run if they're proven as effective as we are suspecting they may be. So the other thing is that you have to know a little bit about the mechanisms of elimination of these monoclonal antibodies. And so the clearance is through the reticuloendothelial system, and there's very little antibody filtered by the kidney. So I don't have all the data yet to prove this, but these drugs are drugs that are probably going to be safe in our patients with cardiac disease and perhaps some mild renal impairment, as we all see, because the mechanism of action is not through the kidneys. So I think, so, we're all busy clinicians and, big pictures here. This does not get cleared through the kidneys. And I have on your handouts some of the finer points if you want to go over them afterwards. Now, at the end of the day, these drugs and the concern of any immunogenicity or adverse effects are target related, and they're based on whether the antibodies are neutralized or not. But at the end of the day, these drugs have not shown a large side effect profile. And I think that's what we have to know as clinicians. And as general clinicians, you may be familiar with some of these compounds in other areas of clinical medicine, such as rheumatology, okay? And the off-target toxicities are much less frequent with the full human antibodies, okay? The fully humanized. Okay, so we're gonna go on here. So I guess the first question is, what is the optimal LDL level for a healthy adult, and is there an advantage to having a lower LDL level? Let's think about that. Well, I'm going to show you some interesting data that's thought-provoking. So there are some human experiments, because people are born, with PCSK9 mutations and loss of function, where we have very low serum LDL levels. And we do see, if you look at these, and I know I'm being filmed, but I want to go over in point, so I'm going to go over in point, and so I'm sorry if the film's not going to show it there. They'll have to edit it afterwards. Okay, that when you have a loss of function of the PCSK9 molecule, the plasma LDL is very low. But you also have low event rates. Okay, am I saying that backwards today? No. Am I saying it? I'm saying it correct. Okay, low cardiac event rates. So in fact, there is, that's right. So there are low cardiac event rates. So there's epidemiologic data to suggest that interfering with the PCSK9 molecule will translate into lower event rates. Now, whether we create a drug that performs this function that translates into lower event rates, the trials are ongoing. But there's good epidemiologic data out there that's suggestive that, something is up here. And so, in fact, the PCSK9 loss of function mutations are found in up to 1 to 4% of the population. And they're associated with a 20% reduction in mean LDL. And they actually show a significant reduction in lifetime risk of coronary heart disease. Now, let me pause as a preventive cardiologist and remind you that when I look at clinical trial evidence and when I take care of my patients, I'm actually in it for the long run. So I'm not there just for the 4 years of a clinical trial to see the effect of something. But especially in the prevention world, where we're debating 0.1, 0.2 millimoles per deciliter per liter of LDL lowering or raising, that these small differences may have longer effects in the lifetime of a patient. And so sometimes we may not see the data we want to see, as we've just seen now, we'll talk about it in a minute, from a recent ezetimibe trial that doesn't show a change in events over 4 years. It might take 7 years in a clinical trial for patients with long-term preventive issues, but you and I think, are in it in the long run for our patients. And that's why when you see an 88% reduction in lifetime risk of coronary heart disease, really in the preventive world, we're talking about lifetime risk, 10-year risk at a time, not the 4 years that you sometimes see in a clinical trial. Okay. So there's no doubt, and we can go into a little detail, that if you actually lose function of your PCSK9, it affects the LDL levels, and I've shown you it actually affects your coronary heart disease risk. In fact, there's several trials, and I'll have you read that up afterwards. But there are actually 2 people out there. Very interesting. So what happens when you lower LDL? Because I'm going to show you some data that shows these new compounds or drugs lower LDL an awful lot. Okay, and that's good, but what does it mean? Well, there's 2 people out there who have been identified, and I think this is kind of neat. This is a real human experiment, okay? With inactivating mutations of both PCSK9 alleles. So they actually have almost no LDL in their body, 0.4 millimoles. Yet, they are healthy. One woman is fertile, normal fertility, and normal development. So it does go to the answer to the question I asked, how low can we safely go with LDL levels, and how low do we need LDL in our body? Well, some people believe after a certain age of 2 or 3 you may not need any LDL in your body, but this is an interesting proof of concept that these people are actually they're both normal fertility and both women that actually have almost no LDL in their body on the basis of a PCSK9 mutation, and yet they're healthy. So that's kind of neat. I thought that was very interesting. Now this is somebody I may or may not be related to, since it's being filmed and we're not mentioning names here. But I brought this up because this is a baby. And babies walk around with almost no LDL levels in their body. Yet they're developing, they're functioning. They're really growing in ways that we as adults don't even grow. And let me tell you, that's because the LDL we see in our systemic circulation, are exposed to or not. We don't want to be exposed too much. It causes coronary heart disease, problems with blood vessel function, is different than the LDL sort of circulating in the body. So this young baby can have brain development and normal development, as we all do, but still have almost no LDL in their circulating system. And I think the other proof of concept are little babies and children. So we have to think about that, because healthy development and brain development has nothing to do with circulating LDL in your systemic circulation. Okay, so let's talk about some clinical trial results with these emerging therapies. Let me tell you that there are, first of all, I just want to briefly talk about the fact that the drugs that raise HDL, the CETP inhibitors, have really, as I mentioned at the beginning, ended in futility for many of them. Large programs, multi-million-dollar programs have been stopped because lack of clinical benefit, and to see that there was no change. There are still a few trials ongoing, but I don't think we're going to see a lot of benefit here. These drugs don't cause harm, but why would we give something to a patient that doesn't help, right? Okay. PCSK9 inhibition, however, I think is the new exciting player on the block. And there are several drugs and compounds by several companies, not just the person who sponsored the company that sponsored the talk tonight. It's Amgen, Sanofi, Pfizer, Novartis, Roche, Eli Lilly, have monoclonal antibodies under evaluation that are soon to come to the market. And you can see the top 3 lines have phase 3 clinical trial data. And the top 2, the Amgen and Sanofi compounds are fully humanized, and the Pfizer compound is not quite as fully humanized. So I think it's just something for us to think about, but there are some exciting clinical trials coming down the road. And so if I look at the program here, for example, looking at evolocumab, you can see, and they're all named after famous scientists, right? Laplace, Descartes, very interesting, Fourier-Glackhoff. I think you will see some exciting data that are coming out in the next few years. And I want to show you the secondary prevention trial, 27,000 patients enrolled, hard endpoints mortality trial. And some of these earlier trials, phase 2 trials, have actually even phase 3 with familial dyslipidemia and hyperlipidemia, have actually already started reporting at our recent American Heart meetings. So stay tuned. You're going to hear a lot more. I'm not going to go into details of every single trial, but there's a huge clinical trial evaluation. And in fact, what we do see, whether it's this compound or the other compounds, they're all actually quite similar, is that we see tremendous LDL lowering with these compounds. So let me back up a minute and tell you, these compounds are not given by mouth. They're not oral. They're injectable. So either once a month or every 2 weeks, you get an injection to lower your LDL. So we're in a very different era, a very exciting different era of a new class of drugs and how we deliver them to our patients to lower LDL. But given to patients, I don't know if you can see the small print here, and we can also see it in your handout, on top of some statin therapy, LDL is lowered by up to 60%. You see this? It says just the big picture, 60%, 60, 56, 53. And so they have statin intolerant trials, and they have also patients who are on either a placebo or ezetimibe as well, comparator. There's some interesting studies out there. And in fact, when you add it onto statins, this is a slide from Laplace and Rutherford trials, I've followed out for several weeks now, for several weeks in these trials, 60%, I'm just going to give you a number to remember, about 60% LDL lowering. So that's why I started to say, how much LDL do you need? And I put up a picture of a very cute baby because we have to remember that we might not need LDL in our bodies. I will tell you that we're going to find this out very soon anyway, whether we need LDL as human beings who are adult human beings, because whether these trials show reduction in cardiac event points or not in the long term, promising, hopefully they will, we'll have lots of patients on many, many months and patient years of drugs that lower LDL significantly to see if it's safe and to see what happens when we lower LDL that much. So we're going to have, so the one thing I want to just show you here is that the change in LDL and HDL sort of goes up a little, not that much. We look at non-HDL cholesterol. Really, these drugs are actually very impressive, even with statins, okay, that we're lowering LDL. The Lp(a) story is kind of interesting. I'm not going to go into a lot of detail now, but there's some suggestion that they may have an effect above and beyond the LDL. We'll wait and see. I don't know. But so there's some effects on the whole lipid profile that somehow seem somewhat promising with these compounds. The other thing is, and if that bar was up a little more, hopefully it's printed out nicely in your handout, the SAEs are very few and very similar to placebo across the trials I've shown you here for at least looking at right now evolocumab. And again, if we look at, there's 52-week data, you know, on top of high dose statins and ezetimibe, we are seeing a very, very significant reduction in LDL. See that number is 60, about 60%. Treated for 52 weeks. We're seeing long, with monthly injections, we're going to start seeing these clinical trials roll out and give us some information. So we see this, and again, we always worry with a new compound about adverse events, you know, those sorts of things. And if we look at it, in fact, really no difference for serious adverse events, any treatment emergent adverse event. I'm always amazed that when you design any clinical trial and you have a laundry list, as you need to, about side effects, that if you look there, we have 75% chance of some sort of effect on placebo. So I bring this up not just for these class of drugs, but for the potential power of suggestion when we're trying to get our patients on the right drugs in the first place. Commonest side effect for all of our drugs that we prescribe is no side effect. There are side effects, but in this class of drugs, there's nothing that actually looks concerning so far. And just to be balanced here, I want to say there are 3, but if not 2 drugs that are coming out of the gate very quickly with phase 2 and phase 3 clinical programs. And then this is the alirocumab clinical trial program, and this is instead of the scientist is all about odysseys and, you know, I guess something interesting in space. My actually disclaimer is that I'm involved in Odyssey outcomes. So I'm involved in the clinical trial looking at patients who have had an MI in the last year getting alirocumab versus placebo. And if you have patients who've had an MI in the last year who aren't at target on statins, call me because we'll get them in the clinical trial. But there are large clinical trial programs, 18,000 patients in this clinical trial that will report in the next few years and are actually interesting and exciting. Okay, and again, this is the other compound that's fully humanized, that's going to have a lot of clinical trial data behind it. And again, we're seeing here, these slides show about 50% LDL reductions. We're seeing tremendous reductions in LDL, including in patients who have familial hyperlipidemia, who are very difficult to treat. And we all probably, although if we're not endocrinologists, and I'm not, have not a vast majority of these patients, but we all have one or two patients in our practice who actually have fairly high LDLs. And you know, the trick for you to sort this out, and that means there's a genetic component, is that if the LDL is over 5, all the pasta, all the junk food, all the weight gain, all the French fries in the world can't get your LDL over 5 without some genetic component. And in fact, the newer guidelines on familial dyslipidemia and familial hyperlipidemia say, for us as clinicians, one of the questions is the LDL over 5? And the Canadian guidelines say treat these patients. But I have a few patients in my practice who've had bypass whose LDLs are 7 despite being on high-dose statins. So these are the unusual patients. But this is promising for these patients with this new class of compounds. Okay, and again, I want to show you to be very balanced. Oh, this time we have an 80% side effect rate on placebo as opposed to 75. I'm being facetious. That these drugs, and both drugs within the class now, are well tolerated and don't seem to have a signal for side effect profile. Okay, and then third, I don't know if it'll be last on the block, but there's the bacoziximab. Don't ask me to say that 5 times fast or tell me to say it right. We'll have clinical trial outcomes, and we have outcomes data looking at patients who are at high CV risk, and these trials will report in the next little while. So again, the mean LDL change, if we look at this compound, is significant. We're up to 50% depending on how we deliver it, whether it's every 2 weeks or every 4 weeks, and we'll wait and see. And these are patients who are having add-on therapy who aren't at target. And I want to just show you something here, because these are sort of the large clinical trial programs that we see with the evolocumab, the alirocumab, and the boxicimab. Okay, and I just want to let you know that, and I don't know if I've said them right, that we will have, you know, tens of thousands of patients in each clinical trial, and look at when they're reporting. So one of these trials is reporting in August 2017. I don't know about you, but 2 years flies by pretty quickly in my life. In January and February. These are not the trials that are built in the clinical trial program. This is the large endpoint trial. So you're going to see a lot more of these drugs and these compounds, I think, in an everyday, even primary care world very shortly. Okay. So I have a question, and we can just think about it, and you can tell me what you think. How will the outcomes of these studies change your management of dyslipidemia? So number one, won't change anything until PCSK9 inhibitors are proven. You're looking forward to trying them when they're available, or you want to see the benefits of lower LDL and patient preference. That will drive your use. In other words, it doesn't matter what the clinical trial evidence shows. I actually think I will tell you that I'm excited about using these drugs, but I'm waiting for clinical trial data. So that's why I'm happy to share your patients to enroll them into clinical trials, because I think we're in an era where we really do need to have evidence-based approach to using medications. So you can think about what your answer might be. Okay. So I just want to summarize, and I'm going to use evolocumab as one of the examples here, that these drugs are tremendously effective at lowering LDL, whether they're in comparison to placebo, or on top of ezetimibe, or on top of in combination with a statin. Very, very potent drugs. Okay, and we have data. This is 24-week data here with alirocumab to try and be a little balanced here. Again, very, very effective. Okay, so I'm going to summarize in a minute what I've talked to you about to date, and then we're going to open up the questions in a few minutes. But there are novel mechanisms for lowering LDL cholesterol, and I think we're going to start seeing some exciting things in the near future. And I think I've tried to go over with you that if we interfere with LDL receptor recycling, okay, or degradation, then it ultimately affects LDL level. And so we have to be careful. That's how these drugs work. They're certainly more efficacious than existing therapies, and to date they have a good safety profile, but with no impact on muscle or liver. But I think I want to end with a big picture before we start discussing patients, opening up for questions about general questions you have about lipid lowering and where we are now. I don't want us to forget the big picture. So first of all, we're talking about LDL and lowering LDL by 60% and getting that LDL down. But if the difference between an LDL of 2.1 and 1.9 or 1.9 and 1.3 in your clinical practice is probably not important at all if your patient is still smoking. So we have to think about it. It's easier for us as physicians to prescribe a medication and one that a patient will take, then work on the more challenging aspects of risk and risk reduction. And so I think we have to put this into the context of overall prevention for our patients. And we have to address these newer compounds in the context of good clinical secondary prevention and then primary prevention care. The other thing, and no apologies to a nice dinner tonight, that most vascular events aren't sudden. They take many years of preparation, and so we have to work on preventive therapies for our patients in the big picture, not just focus on one sort of magic answer. And then my shameless plug for a book I wrote for charity for the Heart and Stroke Foundation that talks about prevention in secondary and primary lifestyle and drugs. And it does talk to patients about why they need to be on statins and why, if you're having sort of that uphill battle as a clinician, why we discuss risk versus benefit. Because I really think at the end of the day, the role for these newer drugs will be on top of good statin therapy.